You have found the Thinking Mind podcast.
Okay, so I'm here with Anya and Rebecca. Thanks so much for joining me.
Thanks for having us.
So I thought it would be good to introduce you guys to the audience, your new hosts for the podcast. You guys are going to be doing interviews. Rebecca, your first interview just got released last week. And Anya, your first interview will be being released next. So I thought it would be good to have a conversation so people can get to know you a little bit. And we'll take it from there and see where it goes, really.
Sounds good.
I guess I'd start by asking, I guess I ask everyone this, but what do you think attracted you guys to work in mental health and psychiatry? Rebecca, why don't you answer first?
I've always been interested in mental health, I think. But I think when I was in med school, I always thought I wanted to become a medical doctor because that was kind of the aim going into it. I think everyone had. And I always tried to put off going into mental health. But gradually, the more I studied and then when I became a foundation doctor, my first job was in mental health and I absolutely loved it. And I remember going into work and leaving and thinking, I can't believe I'm being paid to do this. Because it didn't feel like a job. I was just enjoying myself so much and I looked forward to work every day. And I was going in early to find out what had happened to my patients overnight. And then I had other jobs, geriatrics, ophthalmology, medicine. And I just didn't enjoy them as much and I didn't get the same satisfaction when I was leaving. So I thought I did do oncology, which I did really enjoy. Yeah, at the end of it, I just thought mental health was the one for me. I loved it so much. And by that point, I applied for a CAMS job and then I applied for my training.
And what do you think, what was it about the nature of the work that attracted you?
I think every patient is different. And I think every patient is so complex because everyone's presentation in mental health is dependent on their life and every single person has a different life. So you're never going to hear the same thing or see the same thing. If you compare that to a pneumonia or a heart attack, you kind of do see the same thing. And I don't want to be disrespectful to any other professions, but I did once hear someone say the heart is a glorified pump, whereas the brain is just so complex. And also, I think there's so much that we don't know about mental health at the moment compared to other specialities in medicine and surgery. And I think that makes it a really interesting subject to study and move forward. And I also think in mental health, there's so many avenues you can take in terms of research, in terms of you can really go anywhere with it. And there are so many extra things that you can do. For example, this podcast, which I personally obviously find very interesting, but I think also the general public do. If you compare that to other specialities in medicine.
Mm-hmm. So there's something about the complexity, the individuality of every patient and the fact that there's still a lot of mystery.
Exactly, yeah.
And that's very true. And I think people don't acknowledge how vast psychiatry is just because, we deal with outcomes. Like we deal with a patient with a set of problems. That's basically an outcome that has many different inputs. Like they could have problems going on at a biological level, which is more classically medical. But then they could have all sorts of other problems, psychological, social, obviously.
It fits into every aspect of someone's life, I think.
Mm-hmm. And Anya, what about you?
A lot of similarities actually with what you've said, Rebecca. Like I always found the brain interesting, and I think one of the things that drew me to medicine was, I guess, a desire to get to know people a bit better and what makes people tick and what makes people work. I similarly thought that general medicine or something like that would be the way forward for me initially, but then I started to work and actually I didn't find it as exciting as my other colleagues who went into it did. I met some psychiatrists in my early jobs who spoke about how much they loved their work, and how much they enjoyed their working life, and I think that piqued my interest as well because they just seemed happier than some other colleagues. And then I tried it and I liked it, and I think I then saw sort of bits of mental health in the other specialties that I worked in. So kind of working with, patients coming to A&E with either depressive crises, suicidal, or dealing with the effects of drugs or alcohol. And I felt like I could do more for them than I could, being just who I am and how I work as a clinician. I felt like there was more that I could give to people coming with those kinds of problems. I guess similar to what Rebecca said, it feels like there's a big difference that can be made in psychiatric work and for patients with mental illness. I enjoyed advocating for people in that way. And so, yeah, for me, it just feels like an exciting part of medicine to work in. Yeah, where hopefully through our work, there's a lot that we can do for people.
Yeah, I think what you said makes sense. I also think, unlike other specialties, to be an effective clinician, you have a responsibility to look after your own mental health. Simply because I don't think it's possible to be an effective clinician if you yourself are struggling. Not that you wouldn't have struggles, of course, because everyone has struggles. But what I'm saying is you kind of have to walk the walk. It's easy to be a fat cardiologist. You can be a cardiologist who doesn't take care of your health, and you can still prescribe the correct treatment. I think it's a lot harder to do in mental health. I think you very much have to lead by example. And again, that doesn't mean creating some illusion of invulnerability or omnipotence, like pretending that you don't have any weakness, but merely being open about the fact that you do have your own weaknesses and your vulnerabilities, and then sort of confronting them head on and taking those steps to deal with them. I think this especially applies to psychotherapy, because it's a sufficiently intense intervention that if you have your own unresolved issues, it's going to come into the consultation room. So you really have a responsibility there. But I think it applies even to non-psychotherapeutic work within mental health as well.
I guess the only thing I would challenge in what you've said is I think that is true, but also idealized. As in, I think psychiatrists are still human, and I think we're no better than any of our other specialty colleagues.
Yeah.
In terms of our ability to look after ourselves or be, honest with ourselves. So I think, I think all doctors, we are probably all more effective at being clinicians if we're honest with our own vulnerabilities and look after those. But I think we all fall into traps.
Yeah. No, definitely. It's a thing of constant vigilance. Like it's not, you can never really feel, it's a practice. It's never something that you feel you're done with. It requires constant attention. It's so easy to fall into mental traps, I find.
But I guess at least psychiatric training, again, compared to some of my other friends who are going through other specialty trainings, at the moment, it feels like there's more emphasis on looking after those things, like what you've said. It's talked about and people are aware of, and it feels like the training program tries to look after you, to encourage you to be aware of those traps.
Do you guys think that psychiatric training poses importantly different challenges to training in conventional medical specialties? And if so, what do you think those differences are?
I think definitely there'll be different challenges. I think the things that we see and deal with are sometimes very, very difficult and aren't something that anyone really comes into contact with day-to-day life, and can be really, really saddening when you leave your day-to-day job and go home. And I think there is a skill to be developed that only comes with time, being able to switch off. Or I do think over time people do become a little bit flattened to those things at work. And that's not to say that you're flattened to those things in your outside life. It's probably a skill to separate the two. But there's no doubt about it, the things that we see and hear in our jobs is really, really difficult. And I think I am slightly becoming blunted at work, at least. But I don't want to become too blunted, because I want to still be able to offer that level of empathy that my patients need.
So by blunted, you mean having that element of detachment?
Completely, yeah.
Yeah, which is important to a degree. I don't think you can do this job without having an element of detachment, even if it's you could call it a compassionate detachment.
Yeah.
but still some amount of detachment is necessary just because of the volume of people that we see.
Yeah, definitely.
And the degree of their difficulties.
And sometimes you will meet people that sometimes remind you of yourself as well. And I think it's really difficult in that instance, especially when I have patients that are maybe the same age as me or have come from similar backgrounds as me. I think it's really difficult to try and keep that barrier there because you think I could be in that situation, that could be me. I think that's probably for me been the most difficult challenge so far.
And just so people are aware, one of the reasons why I got you guys specifically on board is you're quite early in your training. So I'm kind of middle end. So I'm hopefully a couple of years away from consultancy. But what I envisaged was bringing some people on board for the podcast that could take the project with them through their training. Are you guys in your first or second year?
First.
Very much first.
So I guess my next question is, you're in the beginning of your training, you've just started being exposed to psychiatry and all the challenges. What then attracts you to doing something like podcasting, and how do you think it might complement your training process?
I think for me, one of the interests is the sort of the public communication side of what doing something like a podcast allows, that you can speak to people who are in some way expert in whatever it is that they do, or in whatever thoughts that they have about mental health or mental illness, and you can help them communicate those ideas and those thoughts more broadly, in a very digestible format. You can have it on in the background. You might not listen to every second of it, but you can take something away, and I think one of my interests is research, but I think one of the problems with research is that actually, the public taxpayer knows so little about what's done. And I think that's no one's specific fault. I think it's just that, some aspects of research are really hard to communicate and really hard to understand. You have to make an effort to communicate it. And I think there aren't kind of specific avenues to communicate things. So I think the issue that then public communication might solve is just, I think when people are better informed, you get better discussions, you get better conversations, and then, at a political level or just at a personal level, it creates more chance for change, hopefully.
Definitely. One of the reasons I started the podcast is because I wanted to cut out as much as possible the middleman between expertise and the public, so that they could get, direct from the source, high quality information about what's going on, both at the cutting edge, but also just in general, the accumulation of knowledge so far. And I think not only is there a lack of communication between academia and the public, but there's a lot of miscommunication. I think journalists often, they're pressured, they have to produce a lot of stories, and it's very easy for them to take a research paper and try and make a headline out of it, irrespective of where that paper fits within the broader context of the field. It's very easy to take a study, and journalists aren't necessarily trained in scientific criticism, so they don't necessarily know what makes a good study or a bad study, or, as I said, they don't necessarily know how that fits into the rest of the research that's been done on a particular topic. And so I think there's a lack of nuance. And I think you're seeing it now in every industry. Podcasting is allowing more nuance, more of a dialectic, an acknowledgement of complexity, rather than, the example I always use, are antidepressants good or bad? As if it's an issue that could be treated with such simplicity, right?
Yeah.
What about you, Rebecca?
I think a lot of what Anya said I resonate with. I think the ability to speak to these people that are experts in what they do is a privilege, and is something that I found so interesting and enticing when I got the email. I like a challenge and I like to push myself, so I thought it would be something interesting for me to do, to see what I could do with it and where I could take it. And I think, like Anya said as well, it's so important that we get the message across from from kind of the backbone where it's coming from research to the public, because actually it wasn't something that I've thought about, but now that you've mentioned it, completely true, that actually what goes on behind the scenes is never really portrayed exactly to the general public and the taxpayer.
So your first interview came out last week. That was with Rebecca Lawrence, who's a psychiatrist who herself has a diagnosis of bipolar. She's had ECT. So if you guys think that'd be interesting, do check out that episode. How have you, Anya, your first interview is coming out next. How have you guys found doing interviews so far? What has been like the challenge of it, do you think?
I mean, I think one of the things for me that's difficult is I have always struggled with being on the spot. So, when like at medical school or foundation year, sort of early years of doctor training, being asked a question by a senior about, what's the diagnosis or what do you think is going on here? My mind just goes blank. And once that's happened a few times, even if it doesn't happen the fifth time, you still think it's going to happen. So you're just a bit of a mess. So I think I was aware that would be difficult in terms of, having a conversation with someone that I know is going to be heard by other people and, figuring out how to respond to them appropriately. Obviously the helpful thing is that you're kind of asking the questions rather than coming up with the answers. Over the first lockdown, I read the Dalai Lama's book, one of his books about sort of, how to live a happy life. And he talks about public speaking and how he sometimes gets nervous, which is hilarious. Just, the idea of the Dalai Lama experiencing anxiety. But he just reminds himself that actually, if he thinks about it as trying to say something important, of course he'll feel nervous. But if he just thinks about it as trying to turn up and explain something to people in a way that they might not have thought about it or share something slightly new with them, then it's fine. Like that's, he's just trying to do that. He's not trying to convince them that he's important or special in some way. He just wants to share something with them. So I'm trying to remind myself of that. But yeah, I think the nervousness has definitely been a big challenge.
Yeah. And you, Rebecca?
I loved it. I really enjoyed interviewing Dr. Rebecca Lawrence. It was really interesting to hear what she had to say. I mean, I wouldn't have picked her to interview if I didn't want to talk to her. I'd already heard her speak at an event that I previously went to and just thought, I want to ask this person more questions, because I think it's something that's not really spoken about, that consultant psychiatrists or professionals have mental health problems themselves. And I think it's very important that people appreciate that, like we kind of said earlier, we are all human, and we have our own struggles. So I wanted to get that across. And I loved interviewing her. I think it was great. And I also feel like personally, on a personal level, I learned a lot from speaking to her. But obviously there were the challenges. It was nerve-wracking doing the first interview. I can't deny that. But no, I really enjoyed it.
Yeah. I mean, I have the same... I think I struggle with feeling tense before an interview. Like, I get really excited about the interview when I'm planning it, and before, it's always a person I really want to speak to. But then on the day, I always hope this will be cancelled. like something will go wrong. And it's interesting to think, why is that? And I think a lot of it is a fear of making mistakes, a fear of being perceived as a failure or doing something wrong. And so I found the main things that help is obviously firstly practice, that kind of raw desensitization of doing something over and over again, and it just getting easier on a sort of unconscious level. But on a more conscious level, it's just becoming more okay with the idea that you could make a mistake, becoming more okay with the idea that someone could listen and maybe not like it so much. And I guess someone who's ambitious could listen to that and say, but aren't you not then going to do your best and excel? But what I would say is that you often excel from a place of relative relaxation and calm. And also it's not about everything you produce being at a really high level. It's more producing at really high volume. And then that allows for the possibility of amazing things to happen. You create a space, you produce a lot. I think this applies to everything, but you create a space where you produce a high volume of work, you do a lot, you're okay with the fact that a lot of what you produce isn't going to be amazing, and then that allows for really great things to happen, hopefully.
Yeah. And I have to say, afterwards as well, I was completely nervous before, but afterwards I came away feeling quite high and ecstatic and felt great afterwards. But obviously before was different. Do you feel the same? Did you feel the same when you came afterwards, after you'd done the podcast?
Yeah, it is exciting. It's cool. Like you've survived. So like the most catastrophic thing didn't happen. And the people that I've spoken to, I've come away, I guess, being reminded of the fact that they are just lovely human people. And like what you mentioned before, Rebecca, like it's such a cool opportunity to just get to have a human conversation with these people. And so I think definitely come away feeling like a sense of accomplishment. You've done something that you thought would be terrible, and actually it was reasonably enjoyable and also really cool. Like, how lucky are we? It's
Yeah, I feel the same after doing an interview. I really enjoy the sense of having produced something that hopefully can be of value to people, that people can take something away from. So, Anya, what's your upcoming interview about?
So I spoke to Dr. Marta DeForti and Professor Robin Murray, who are both consultant psychiatrists in South London, and they are also academic psychiatrists, so they do a lot of research. Robin originally started off doing a lot of psychosis research, but now one of the things that they speak about most is cannabis and its relation to psychosis. So we speak about kind of the research and what we know about the links between cannabis and psychosis, but also a lot of their clinical work. So Marta DeForti runs a clinic for people who use cannabis and have psychosis to try and help them to, sort of harm reduction, so try and reduce the amount of cannabis that they use, which is really cool and really novel. And they also run a peer group where sort of people who use cannabis can come together now in a virtual format to talk about all things cannabis. And again, I think it's a really nice supportive environment.
Yeah, and I think it's really important. We've had Robin Murray on the podcast before, just talking about psychosis, but I think addressing the link between psychosis and cannabis is very important, particularly for the general public, just because we're in a very strange phase in the West where a lot of drugs are being decriminalized. I believe cannabis has been decriminalized in the States. It's been decriminalized in Malta, where I'm from, and I think there's this increasing perception that cannabis can do no harm, that it's barely even a drug. I think Marta DeForti talked about that. And there is some truth in that many people can use cannabis without problems, but an important minority and significant minority can have huge problems. It can bring on a psychotic episode or make it worse. I'm sure you guys have seen as well, acute psychosis exacerbated by cannabis, which went away when you just took away the cannabis and didn't even need formal antipsychotic treatment. Have you guys seen any cases like that in your work so far?
I have, definitely. Yeah, and I've definitely seen people's lives that have potentially been ruined by cannabis. I've seen young men come in who have, obviously we don't know for certain the cause of it, but likely cannabis-induced psychosis, and they get discharged after a month or so and they start smoking cannabis again. They come back, and I've seen patients that have been in and out for years, kind of following the same pattern of being well, stop taking their medications, start smoking cannabis again, and then they come back. And unfortunately, with that pattern, it's really difficult to sustain a job or a really good quality of life. And I don't think, from my perspective, the public really realise that seriousness. And I agree with you, it is a minority and most people will not be affected. But I think it's a really important thing for people to be aware of, especially where we're all moving towards decriminalising cannabis. I think the public really need to be aware of that risk, because although low risk, the result that it can have on someone's quality of life is drastic.
Very drastic, yeah. I think what will end up happening in the future is we'll have polygenic risk scores for psychosis, by which I mean we'll know enough about how and which genes increase your risk for psychosis, such that we can test someone's DNA and give them an indication of how vulnerable they are towards developing a psychotic illness. And then hopefully, if polygenic risk scores are done for everyone, I interviewed someone named Robert Plomin recently about genetics, who seems to indicate that's probably what's going to happen in the next 10 or 20 years. Then someone with a high risk for psychosis will know that that cannabis is a potentially very, very dangerous drug for them.
Do you think people would still believe it though? Do you think patients would actually we would tell them that and they'd go on to not smoke cannabis?
I think it would help a lot. I don't think it will necessarily work for everyone, but people respond to what they perceive, I think, to be hard scientific facts and biomarkers. And I think in psychiatry we don't have enough of that.
Yeah, definitely.
Necessarily. So I think it will help a lot. I don't think it will resolve every case for a few complicated, probably psychological and social reasons.
Yeah.
But it'll definitely help.
It's I guess going back to the cannabis psychosis again, it's the nuance though that is difficult. And I think, the studies have been done to show that the link is there between cannabis and psychosis. But as ever, it's not the only thing, and it's so tied up with so many social factors that it is really hard to separate exactly what's causing what. So I think, yes, it's a problematic drug for some people, but I guess I personally feel like to get people on side, it's finding the right way to communicate that information. I guess like thinking back to drugs education at schools, you have a police officer who comes in and tells you that drugs are awful and you will die. And you're like, oh gosh, okay. And then you go to university and, or even at other times at school, inevitably you will come across people who use drugs for fun, because lots of drugs are fun. That is why people use them. And like, if you can't, if all you say, like, cannabis will give you psychosis, cannabis will get you addicted, and you will have a terrible life, just no one's going to listen to you. So yes, so like something like...
Yeah, exactly. I mean, that's wrong, right? That's like self-evidently wrong.
Yeah.
Because many people will use cannabis and not have any problems whatsoever. I think that's a fact. Many people will use cannabis and have some degrees of difficulties, which may vary depending on how much they use, how vulnerable, what's going on in the rest of your life, the social factors you mentioned. And then maybe there's a tiny minority where maybe they're at really high risk and it could give them a psychotic episode, which of course would alter their life significantly. And that's why we're doing 2-hour podcasts about them.
Yeah.
Right? Like I think the one you did with Rob and Maria and Marta de Forti is like 1:45.
Once you cut out some of my ums and ahs, it's closer to the hour. But I guess and I will move away from cannabis because clearly I love talking about it. But I feel, and I may be wrong, but I think even in psychiatry, I think we as psychiatrists, we can get really fixated on the drugs that our patients use. I think because it's something very tangible that we can tell them to not do. And I think it feels to me like, yes, I'm sure there will be people who have, their benefits are 100% in order, their flat doesn't have leaks, the medication is spot on and doesn't give them side effects, so they don't mind taking it. And yeah, all right, like they don't have an addiction to cannabis, but they use it and it makes them more unwell, and it is, as simple as that. You cut out the cannabis, they'll be fine. But I feel, I guess I worry that we say, well, they just need to stop using cannabis. And I think it's A, not as simple as that because it's addictive, and B, it's, it might be the only thing that brings them joy in their lives, even if for a brief time, and it makes them relaxed, again, even if for a brief time. And it might just make the pain of their social situation slightly more tolerable. And I guess I worry about how black and white. That's been something that I found hard, in work this year. It feels so concrete, even in a specialty where actually, like Rebecca was talking about, we do take the whole person and their whole life.
Yeah, no, 100%. We definitely need to move away from black and white thinking on either end of the spectrum, right?
Yeah.
I mean, even like the last point I'll say on cannabis is, as well, not all cannabis is the same. It's not really one drug. It depends a lot on the THC content. And one of the reasons why this problem has gotten worse is simply because the THC content has risen so dramatically over the decades, whereas you can have cannabis with lower THC content that's much less likely to cause these difficulties. So there's so many factors on there that are involved.
Yeah.
What areas in psychiatry are you guys excited about learning more about? Where you think, because there's a lot of different subspecialties and different areas of thought and research. What areas do you think you guys are most keen to learn more about?
I myself am only just starting out my psychiatric career, but I think personally I'm heading towards the direction of child and adolescent mental health. I worked on an inpatient ward for 6 months, which was really challenging, and I think I came away from it thinking I don't want to do that. And now I'm working on an 18 to 65-year-old male inpatient ward. And I did a few locums back on my old ward the past few weeks, and I've realised actually how much I really enjoy CAMS. I find the patients so complex, and I don't mean that in an offensive way at all, but children and adolescents aren't really able, most of them, depending on their age, obviously, to articulate their feelings. And that adds such a difficult element to treating them compared to if you've got a 50-year-old who is telling you what's wrong with them because they've had a breakdown of their marriage, they're unemployed, XYZ, whereas you get a 13-year-old that's self-harming their face and they can't tell you why they've been cutting their face for the past 3 days, and you have to work with them, but also you really have to think deeply with your team and yourself about what is this individual trying to tell me, because they can't tell me it straight up. And also encompassing CAMS as well. I find autism and ASD very interesting, and other diagnoses that come close to ASD and are closely linked, such as ADHD and OCD, which are quite common in CAMS.
That's interesting what you said about them not being able to articulate their difficulties. But I think what it also represents is an opportunity, the lack of ability to articulate their difficulties. Because when you see a 50-year-old, you're often seeing someone who's the narrative that they've constructed about their life is really ossified and hard to shift, and can often be very unhelpful. Like a lot of what we focus on in psychotherapy is like what Carl Rogers, who was kind of very important in person-centered therapy, he said that psychotherapy is a move from psychological rigidity to psychological flexibility. The more flexibly you can adapt your mindset to the different challenges that life throws at you, the more psychologically healthy you'll be. And so I guess when you're working with children and adolescents, you have an opportunity to help them construct that narrative that's more helpful and also more flexible.
Definitely, yeah. But I think it's easier said than done.
Yeah, I mean, very much so, yeah.
Yeah,
definitely.
but I see your point.
What about you, Anya? What areas are you interested in?
So I am really excited to learn some psychotherapy skills. We've just had sort of our introductions to psychotherapy, kind of how it will practically work, lectures recently, and I think sort of cases are going to be assigned quite soon, and I think I'm excited for to kind of develop those skills. I think to have the supervision of how to treat that patient. I think it will be really cool to have one patient that you look after for a year and work with and try to help, and that you have kind of, I guess, fairly close supervision for that one patient. So I think that will be cool, and I think I'm excited to see how I can, I guess, hopefully work those skills into day-to-day psychiatric life as well. Maybe, I don't know if you found that you can work your psychotherapeutic skills into into contexts that aren't just formal psychotherapy.
Yeah, I mean, for me, learning about psychotherapy was quite game-changing. Obviously, I'm training in it, but in answer to your question, 100%. And not only do I think you can transfer skills from psychotherapy to day-to-day psychiatric practice, I think you should. And I also think it, like, doing psychiatry without a bit of a psychotherapeutic backbone is much more dilute and much less effective, I think. And that's, I can think about different schools of thought, and even just off the top of my head, learning to listen and to get patients to speak spontaneously like you would in psychoanalysis is really helpful, because you get people to understand themselves a bit better. Learning a little bit about dialectical behavior therapy and a bit about how to regulate their emotions, you're going to use every day. Learning a bit about how people construct their experiences by, linking their behavior, thoughts and emotions, as you do in CBT. Again, these are crucial things which are going to apply to most of the patients we see. So being conversant in those skills and those theories, I can't imagine doing my work without that.
And I think it's from a position of not having properly started it yet. So this may be wrong, but it feels so practical. Like, I so often on my day-to-day job, I have felt frustrated by my inability to really do anything to take away the suffering that someone is experiencing, in that moment or in that week. The medications take time to work. Whereas the types of things that you've described in terms of knowing how to, I guess, explain to someone how they can regulate their emotions and guide them through that process. I'm sure it doesn't work for everyone, but how awesome is that if you have that you can give to someone?
Yeah, and the funny thing about it is a lot of it goes unsaid. A lot of psychotherapeutic skills, for example, learning how to listen properly so you can be more containing. The patient might not necessarily have any idea that you've consciously used skills that you've acquired in the room, and yet they leave the room feeling more relaxed, feeling like someone has heard them, feeling hopefully a bit safer, feeling a bit more confident. A lot of the skills are actually non-verbal, and they're not like formally. A lot of psychotherapy isn't telling someone, but almost demonstrating. So, for example, you demonstrate acceptance towards a patient or a client, and they feel more accepting of themselves. Things like that. So that a lot of it's very demonstrative.
Alex, do you find you ever use your psychotherapy skills with your friends when they come to you with problems going on in their own lives?
Yes. I don't know how much I'm going to elaborate on that, but I do. I'm in this job because I spend a lot of time thinking about why people are the way they are. And also a lot of the skills, once you learn them, you kind of internalize them, and they just seem like automatic responses. I think actually talking about how you use psychotherapeutic skills once you've learned them in your personal life is very important, because I think they can be overused or used badly. So I think if you are training in therapy, you have to be really conscious about what you're doing with people in your life outside of the therapy room. I think you have to consciously work on not being a therapist with them. And that doesn't mean, for example, not listening properly or not containing someone emotionally, because those are super helpful. But I try and as much as possible be like a normal person outside and not put on that therapist hat to the degree that I can.
Alex, do you have anyone coming up that you're going to interview that you want to tell us about?
Yeah, so my next interview is with someone called Dr. Ian McGilchrist. So he's a psychiatrist that actually trained at the Maudsley a long time ago. And he wrote a book which came out in 2010 called The Master and His Emissary, which is about the difference between the left hemisphere and the right hemisphere of the brain. Because I think most people have know a little bit about the differences, but there are a lot of misconceptions. For example, that the left hemisphere is logical and the right hemisphere is artistic. And that's not actually quite how it is. So he goes into those differences in a lot of detail and nuance. He thinks that the left hemisphere and the right hemisphere actually see the world in a different way, that they see the world as a totally different place. And he also thinks that as a culture in the West, we've become too left hemisphere dominated, in how we see things, and that's causing a lot of our problems. So I think, to break it down as concisely as possible, I think he sees the left hemisphere as about focus and deconstructing things into their component parts, and the right hemisphere is about appreciating the whole picture, the whole gestalt, how it appears at once. And he feels that the left hemisphere should be essentially subservient to the right hemisphere. So the left hemisphere is the emissary and the right hemisphere is the master. But he thinks as a culture we've become too left hemisphere dominated, that we can't see the forest for the trees, essentially. So I'm really looking forward to that interview, yeah.
What's your favourite part of training been so far?
So I really enjoyed doing my psychodynamic training, which is seeing someone, as you're about to do, for a year of psychodynamic therapy. And that was in kind of the first half of my training, and now I'm in the second half. And what I enjoy about that is you have a lot less commitments like exams and things like that. And you have a special interest day, so a day to do whatever you want, essentially. And so in the second half of training, you're really free to start constructing your own career. So you can think much more consciously about, having acquired a certain base level of skills, you can think about really what you're interested in and then how you can become more involved with that. And so that's why I'm doing things like this and my more in-depth psychotherapy training. So I think the registrar years are really great for that reason.
Do you have any tips for us as young trainees?
So I guess the tips are related to what I've talked about already, which is there are some base level commitments which you have to get out of the way, which are important. I don't think you should neglect them. Preparing for your exams, making sure you can do some of the fundamental things that all psychiatrists should do. But then, having done that, I think you should then follow your enthusiasm. So find what aspects of the job or what areas within psychiatry make you feel engaged and fascinated. And the reason you should do that is because getting good at anything is going to require so many hours of hard work and diligence. Ultimately, it's the enthusiasm that's going to guide you through. And also, that level of engagement and fascination is a signal that not only is it useful for you, but in all likelihood, it's going to bring value to other people. So if I'm doing a talk about something that I'm interested in, I'm also looking to see when we used to be able to do talks in person, you want to look and see how people respond. And there is a really particular look that people have on their face when they feel engaged and fascinated. So you're constantly looking for that resonance. Like, am I boring the person, or are they really grappling seriously with what I'm talking about? And obviously people are different, so people have different interests, but yeah, so I would say follow your enthusiasm, follow what you could do. At the beginning of the podcast, you said, Rebecca, I can't believe I get paid to do this. And that's the feeling, that feeling where if you could actually get paid for it, it would be like a bonus. All right, guys, thanks for joining me. I look forward to seeing interviews you guys make.
You are listening to the Thinking Mind podcast.
If you enjoyed today's podcast, we'd love it if you share it with a friend, or you could give us a rating on Apple Podcasts, Spotify, or wherever you listen. If you fancy it, you can even buy us a coffee to support the team, and the links for that will be in the show notes. Thanks for listening.